200, but I didn't show in any of the videos, I do make sure that there's at least 150 to 200 centimeters of distal common bowel. The part that concerns me is how we measure the 200. So you can see if I make a mistake and I measure 10 centimeters instead of 5, and I think they are 5 centimeter increments, I will have made a 200 centimeter limb, biliopancreatic limb be 400 centimeters. And so no matter how you measure your 200, you have to, when you're finished, measure the distal bowel to make sure you have enough bowel that the patient will not develop malnutrition from a short common channel. So I will measure not necessarily the total limb length, because when I don't think we have discovered exactly what total alimentary limb length means if we're going to change lengths of these different measurements. So if you have 150 to 200 centimeters of distal bowel after you have created your anastomosis, you will be fine. I only had one patient that I took care of from another surgeon. And when we measured the distal bowel, he was very malnourished. There was only 150 centimeters of distal bowel. And I don't know what error was made in the measuring because I wasn't there, but we measured proximal was close to 500 centimeters of bowel, measuring the same way that I showed you how I do it with 5 centimeter increments. I think each surgeon has to have a very confident way that they measure. And we've seen videos online where it's all estimated, 5, 10, 15, 20, 10, 20, 30, 40. Those are not very accurate. And so each surgeon has to develop his own way in these types of operations where limb lengths are important. The answer to that question, and I think this is where we as surgeons have to practice the art of surgery. It makes sense that if it's 10 meters of small bowel, that we would proportionately increase the length of the biliopancreatic loop. And I think that it's not unreasonable to go to 300 centimeters, 400 centimeters, but there is no right answer to that. If you look at the experience with Sadie, we're seeing 250, sometimes 300 centimeters for the distal common channel is what the minimal amount is needed in order to avoid malnutrition. So Michel Gagne has raised the question, is a mini bypass just a different form of a Sadie with a pylorus? Maybe it is. What the Sadie tells us is the minimal amount of length needed to maintain nutrition. And if there's a difference between a Sadie and an MGB in how that minimal length is used, we're going to have to make longer MGB limbs and know the total alimentary limb length and publish those results so that we can see if there's a difference. But I'm confident with what we've done with Sadie to know that we have a 300 centimeter or a 250 centimeter common channel is able to maintain proper nutrition. We should be confident about that. So lengthening it, depending on what each surgeon sees, in a field that hasn't published yet an instruction manual for the 10 meter bowel length over the 6 meter bowel length, is where we as physicians have to bring what we know best to the care of our patients.